Welcome to this explainer. Today, we're diving into one of the most absolutely crucial, yet kind of tricky, bedside assessments in acute care and anesthesia. We're talking about evaluating pulmonary aspiration risk using Point of Care Gastric Ultrasound. We're going to break down the anatomy, the exact sonographic protocols, and the risk stratification models that basically empower you to make safe, real-time, evidence-based decisions right there at the patient's bedside. Let's get into it. So picture this clinical scenario. A patient is rolled into the ED or the OR, and they need urgent airway management. Maybe they have altered mental status, or there's a serious language barrier. You literally have no idea when they last ate or drank. What do you do? Because proceeding blindly with intubation carries this devastating risk of pulmonary aspiration, right? A complication that is directly tied to severe morbidity and mortality. You really need an immediate, objective answer about exactly what is sitting in that patient's stomach. Okay, let's just lay out our roadmap really quick. We're hitting pulmonary aspiration risk, anatomy and prep, our 3-step protocol, calculating gastric volume, the new GLP-1 complication, and finally, pitfalls and pathologies. Kicking things off with Section 1, the pulmonary aspiration risk, and essentially, why we even bother scanning in the first place. Gastric ultrasound, or GUS, is our non-invasive, immediate solution. Think about it. When a patient's NPO, or nothing by mouth, status is a giant question mark due to neurocognitive issues, trauma, or maybe conditions that cause delayed gastric emptying like severe diabetes, we just can't rely on standard fasting timelines. They don't work. Gastric ultrasound lets us actually peer into the stomach in real time, right before giving anesthesia or doing an emergent intubation, to definitively nail down their aspiration risk. Moving right along to Section 2, anatomy and patient preparation, we have to get set up for success before the probe even touches the skin. To pull this off, you aren't trying to visualize the entire stomach. You're specifically hunting for the gastric antrum in the epigastric area. Why the antrum? Because it's consistently located and it actually dilates proportionally with whatever is in the stomach. To find it, you're looking for a few key landmarks. You've got the bright left lobe of the liver anteriorly. Posterior to the stomach, you'll spot the pancreas, plus the pulsatile aorta or the compressible IVC. And then, right between the aorta and the antrum, you've got the superior mesenteric artery, acting as an awesome depth guide. Once you line those up, the antrum pops right out as this distinct round or oval structure wedged between the liver and the aorta. Now, that anatomy heavily dictates how you position your patient. You're always going to start with them completely flat, the supine position. But to get the absolute best assessment, you've got to roll them into the right lateral decubitus, or RLD position, with their right arm up over their head. This shift is a total game changer. Gravity takes over and shifts any existing gastric contents directly into the antrum. So the RLD position is for sure the most sensitive way to detect and measure that volume. Which brings us to Section 3, the 3-step ultrasound protocol. This is your clinical standard. Think of this as your standard operating procedure for the ER or OR. It's a super logical, linear 1-2-3 punch. Step 1, obtain the view of the gastric antrum using the landmarks we just mapped out. Step 2, assess the contents qualitatively. What's actually in there? And Step 3, if you see fluid, assess the volume quantitatively to pin down the exact level of risk. And this brilliantly illustrates the 3 distinct sonographic patterns you're going to see. If the stomach is empty, the antrum is contracted, giving you this very clear target or bullseye pattern. If there's fluid, that target gets disrupted and turns uniformly hypoechoic or anechoic. Basically, it looks dark. But if they've recently eaten solid food, you get this frosted glass or ground glass look. It's this messy, heterogeneous mix of food, fluid, and air. And listen, the second you see that frosted glass appearance, stop. You're done. The patient is instantly a high aspiration risk, no matter the volume. Now, if there's no solid food, but you do see clear fluid, we jump into Section 4, calculating gastric volume to stratify that risk. This is where we use the PERLIS antral grading system. It's a fantastic clinical tool, but keep in mind, we only use this for patients with clear fluids, absolutely no solids or thick fluids. It's basically a 3-point checklist from 0 to 2 that helps predict aspiration risk by figuring out if the volume we're seeing is more than just normal baseline secretions. So here is how that logic breaks down. Grade 0, the antrum is empty whether they are flat on their back or rolled over. Boom, low risk. Grade 1 means you only see fluid when you roll them into that RLD position. Because it needs gravity's help to pull there, it means the volume is negligible, just normal baseline secretions. So still low risk. But grade 2, This means you see fluid while they are flat in the supine position and when they are in RLD. That tells us we're looking at higher than baseline secretions, immediately flagging this patient as high risk. So, the absolutely crucial point here is understanding the physiological threshold behind these grades. And that magic number is 1.5 milliliters per kilogram of patient weight. To put that into perspective, this specific ratio is the red line. It's the exact threshold that separates totally normal, low-risk baseline secretions from a clinically significant volume that literally puts your patient in danger. To actually get that volume, you measure the cross-sectional area, the CSA, of the antrum from serosa to serosa while they're in the RLD position, and you plug that into a predictive mathematical model. Then, divide that volume by their weight. Less than 1.5 milliliters per kilo, low risk. Proceed with standard care. But if it's over 1.5 milliliters per kilo, you've got a high-risk situation on your hands, and that dictates action. You either delay an elective surgery, or if it's a true emergency, you go full throttle on aspiration precautions like doing a rapid sequence intubation. All right, pivoting now to section 5, the GLP-1 complication. This is a massive modern challenge. We're talking about the explosion in popularity of GLP-1 agonists for diabetes and weight loss. The crazy thing is, the exact mechanism that makes these drugs work so well, increased satiety and purposefully delayed gastric emptying, is a total nightmare for airway management. You can have a patient strictly follow the NPO after midnight rule perfectly, and they still roll into the OR with a stomach completely full of residual food or fluid. It's wild. So multi-society guidelines have had to adapt. The rule of thumb now is to hold daily formulations on the day of surgery and hold weekly formulations a full week prior. You've also got to screen for GI symptoms like nausea on the day of. But here is the biggest takeaway. Instead of just blindly canceling a surgery because someone forgot to hold their meds, gastric ultrasound steps in as the ultimate tiebreaker. You scan them. If they're empty, you can safely proceed, saving everyone time and avoiding costly cancellation. Finally, let's wrap up with section 6, pitfalls and pathologies. What could trip you up here? Well, you really need to be aware of air. Think about the stark difference between a truly empty stomach, which gives you that clean bullseye, and a stomach full of gas. Air creates these acoustic artifacts that we call dirty shadowing or a starry night effect. It can completely obscure your view and actually trick you into thinking the stomach is empty. If you see that dirty shadowing, don't just shrug it off. Reposition the patient to the RLD position. That usually shifts the gas out of the antrum and clears up your view. Also remember, even though we are just looking for fluid volume, it's still an organ, and you might stumble upon some incidental findings. You could spot simple gastric cysts or the funneling of a hiatal hernia. You might even catch lesions from Menetrier's disease or thickened walls pointing to gastric adenocarcinoma. And, side note, if your patient has altered anatomy, like they've had a gastric bypass or a sleeve gastrectomy, the utility of this whole protocol drops significantly. Which really brings us to a fascinating question to leave you with. As pharmacology keeps evolving and delayed gastric emptying becomes more of the norm rather than the exception, are the days of the universal nothing by mouth after midnight rule numbered? With Point of Care Gastric Ultrasound, we finally have the tool to stop blindly watching the clock and start making precise, individualized assessments of the actual human being in front of us. Thank you so much for joining me for this explainer. I really hope this gives you a powerful new framework for tackling aspiration risk head-on.